Well, good evening, everybody. Thank you for coming out tonight. There's some familiar faces, there's some new faces. I'm delighted to meet everybody. Know that it's my honor and delight to be here with you tonight and talk to you about a topic that sometimes is a taboo subject, one that nobody really wants to talk about necessarily, but I think somebody or some of us do want some answers about some of this. And so that's the topic here surrounding erectile dysfunction. Now, we're holding this talk here in the midst of Prostate Cancer Awareness Month. And absolutely, it is so. And so we're kind of giving attention here to men's health. Men are important. And erectile dysfunction does relate to prostate cancer management, surgery or radiation. Some of you may be familiar with this yourself or through others that you know, family, relatives. And prostate cancer, of course, is a very significant disease. You know, we do hear about celebrities that pass. I think there was one that just passed the other day, Mr. Gould. And we always have to be aware that this cancer is the leading malignancy in men in the United States and second to lung cancer among malignancies that claim lives. So it's very, very important that we recognize that. And certainly one of the issues that surround management of prostate cancer is the potential that a man could experience complications from treatment, including erectile dysfunction. And therein is perhaps one of the challenges about prostate cancer management. And there are many controversies that surround prostate cancer. And I'm deviating a little bit from the talk tonight, but I think it is something to recognize that these complications arise and sometimes dissuade men from wanting to move forward and get detected and treated for fear of the complications. So we're going to talk a little bit about some of the factors or health conditions, if you will, that are related to erectile dysfunction and how we can move forward with a constructive way of handling it. Now, I also have the opportunity while I'm here tonight to tell you about a book that I wrote. I not only do sexual dysfunction management, I do a lot of prostate cancer surgeries and do have a strong sense of purpose in the area of prostate cancer management. All right, so let me move forward without much ado. We're going to talk about tonight erectile dysfunction, exploring options for treatment. So let's just kind of launch into this. Now, sexual dysfunction treatments have been available for a long time. They date back to antiquity, with many countries offering different kinds of substances that almost resembled the appearance of sexual organs, and that perhaps was the idea that maybe these sort of therapies might have some usefulness. It ranged from rhinoceros horn, oysters, cloves, ginger ointment, even things that you put into the urethra, the urinary channel, which unfortunately sometimes could claim lives. These guys, I guess, are so desperate to treat their erectile dysfunction, it was worth it all, I guess, to develop these kinds of therapies. More recently now, in the past century, things have moved forward with management that has ranged from psychoanalysis to various kinds of devices, and we still have devices today, and you can see the timeline of some of this, to really in the past 2 decades or so, really development of what we call pharmacotherapy. That is medications that we think really have a potential role here to treat erectile dysfunction. So we've actually come a long way. We've come a long way in our thinking about the diagnosis and management of this disorder, ED, erectile dysfunction, and certainly to recognize this being a term that may be a bit more euphemistic than what we had used in the past, which is impotence. And of course, unless you've been on Mars the past 10 years, everybody knows about some of the new oral therapies, Viagra, Levitra, Cialis, well-established scientifically and clinically demonstrated by clinical trials, therapy that we know can treat erectile dysfunction. And I'm going to touch on this a little bit more as we go further along, this development in the field. But this has helped revolutionize the management of erectile dysfunction, raise consciousness here, hopefully in a positive way. And also from my perspective as a professional in the area, just to let men know that we can address this problem and recognize the importance of dealing with erectile dysfunction, that it does impact lives, it has associations in various ways with regard to other health conditions, that it does impact quality of life. To address it does improve relationships. There's so many reasons why this is such an important subject matter to deal with in a very constructive way. So by way of overview, I'm going to speak about really where we are in this field now of erectile dysfunction management with some general principles. I'm going to speak to you about what kinds of concepts we think of from a clinician's perspective to try and constructively handle it and give you kind of a feel for what that's all about. Some basics about diagnosis, okay, and also just where we are with current treatments in the field. Now, as I mentioned briefly a moment ago, we're speaking specifically about erectile dysfunction, which is the pathologic correlate for erection, okay, because I want to be clear in our speaking about what we're talking about. Because even among us urologists in the past, we would use impotence in a almost pejorative way and be non-specific about it. And even when we're trying to converse with patients, was it a matter of erections that weren't working, a man's sex drive, maybe his ejaculatory or orgasmic function. And it's important for us to really understand that all of these are different aspects of a man's functioning, and they may have different associations and different ways to address that. So this is just meant to say that currently in the field we do recognize that there is such a thing as a male sexual response, and there's a cycle that is associated with this. This actually mimics what goes on the female side as well. All right, so there's arousal, which is erection. There's orgasm and ejaculation. There's satisfaction and resolution, and then there's desire or libido. And there are correlates with that. And the correlate, of course, for erection is erectile dysfunction. And you can see there's various other disorders here. This is just other things that we have to think about from the specialty area in terms of trying to sort out what the problem is. Now, the talk tonight is mainly really geared towards erection issues. But I'm glad to field questions later on if you have some other questions that may have to do with orgasmic issues or even libidinal issues. Libido, we call it libidinal, the adjective for having libido problems. All right, so first, what is erectile dysfunction? Erectile dysfunction, ED, has now had a definition that we've developed in the past 20-ish years, the consistent inability to attain and maintain an erection of sufficient quality to allow satisfactory sexual intercourse. So it sounds like we're medicalizing everything, but we want to be specific about what we're talking about so that we don't end up treating the wrong thing. And what we recognize is that it really is a subjective complaint. So the patient or his partner has to tell us that's a problem. We accept that that's your problem if you tell us it is. And of course our job, and I'm going to mention this later on a little bit more, that our job is to try and look for disease associations and perhaps think about how we can correct the problem, the presenting subjective complaint, by addressing surrounding conditions that can be associated with that complaint. And know that as we manage erectile dysfunction, it is my belief that this is a process that we can do in a very forthright, very thoughtful way to address this problem. So what are some of the basic concepts? I think that it is important to think about detecting it early, because I think that there's some reasons to address erectile dysfunction. I think that there's ways now that we think about managing it, and I'm going to touch on this here. Goal-directed means we accept that patients participate with us to decide what makes sense for your management. That's what goal-directed means. And what's happened in the past 20 years is we have now a diversity of options that we did not have 25 years ago. 25 years ago, back when I was a resident at Hopkins training in surgery, we would just give a patient a prescription of yohimbine. If that didn't work, think about a penile implant. I think we have a range of options. We're going to talk about these, and so therefore we know that there are options that are easily administered, they're reversible, they don't commit you to a penile prosthesis, and therefore a lot of these things are options that we try to figure out what makes sense to you, what's your preference. So that's what that's all about. We recognize the importance of the partner. I believe erectile dysfunction is a couples issue, and I certainly applaud all the spouses that have come out tonight, because it's a wonderful thing that you're here to support your spouse having any kind of issues in this way. Know that cardiac risk assessment is part of the equation. Having sexual activity many times relates to cardiovascular illness. And after all, sexual activity does require some exertion too. So there is this component of being aware of a man's cardiovascular health status that can impact on how we make decisions about erectile dysfunction management. So I'll talk about that. There's a step care approach. Sounds fancy, but it kind of tells you how we go about management philosophically. That there are some simpler things to offer generally first, and more complex things we offer down the road. So you're going to hear about some of that. Okay. Again, I talk about how patients and spouses participate in their decision making, and then follow-up care is an important principle that we always try to follow through and try to figure out whether we actually resolve the problem or whether we need to do something more. All right, so we're going to touch on all these things here briefly. Now, detection implies these kinds of things here, that we do recognize that erectile dysfunction may have various risk factors associated with it. And if a man may have other health illnesses that we think are highly associated with erectile dysfunction, then maybe we can just be forthright about saying, sir, we can address this kind of problem. Other men who have diabetes have erectile dysfunction. Other men who have heart disease have erectile dysfunction. Let's recognize that this could be an issue here. Can we resolve that? So understanding disease states that relate to it, knowing what high-risk populations may have these conditions, and then, and I'll show on the slide here, we also have other tools we use, including questionnaires that we use to almost break the ice when you come in to see us, just to kind of get us all thinking about, how severe is the problem, what's the nature of the problem, these sorts of things. Now, I thought this slide would be illuminative because it helps show the kinds of presentations we see in urology clinics in terms of conditions that patients have presenting with erectile dysfunction. And you can see that vascular diseases, diabetes certainly predominate as portions of the pie. Vascular diseases range from anything from having peripheral vascular disease, coronary artery disease, cerebrovascular disease, people who've had stroke kind of disorders, hyperlipidemia or hypercholesterolemia, referring to high lipid levels, high cholesterol levels, hypertension, that is hardening of the vessels, and the fancy medical term is arteriosclerosis. So all of these are vascular conditions that we think fall under this category, and not surprisingly, isn't getting a penile erection a matter of having good blood flow to the penis? I mean, that's vascular. So the insight here is that anything that you have that could be a vascular problem could affect the circulation in the genital region as well. So really not a surprising concept. Now, believe it or not, I can tell you 25 years ago, even specialists in the field thought that 80% of presentations were all right here. Something's wrong with you, psychological, you're mental, emotional. I think we really understood, and I'll show you some slides here to come, understood that there really are physical issues, health conditions, comorbidities we call it, that really are associated with most presentations. Taking an about face on this, instead of 80% psychological, 80% really physical. So we really kind of rethought this all through. You can see other factors that are related from medications that people can be on that can affect your erections, various kinds of surgeries in the pelvic area or radiation or trauma in the pelvic area. Okay, so you can see there are a whole host of elements, factors, conditions that could relate to why a man has erectile dysfunction. So it's understandable much of the time. What's also profound is that we've looked at disease relationships in this field. So I've mentioned some of the things that are associated, but the odds ratio or relationship is that there's like a 4-fold higher rate among diabetics having erectile dysfunction. In general, about 20% of the American population has erectile dysfunction. 20%. Among diabetics, 75%. 75%. So if somebody's had diabetes, the odds of that person is going to have trouble with erections at some point, and I won't get into all the other nuances, but just leave you with that general thought, that 75%, 3 out of 4 guys with diabetes are going to have erection problems. It's just real. And these are some of the other odds ratios. You can kind of say, well, what's 20% times whatever? And that tells you in these disease categories, those percentages of patients with these kind of conditions are likely to experience some trouble. Now, you see I have prostate disease on this, and this is kind of a new insight in recent years. We used to think that just having prostate difficulties, mainly urination problems, had no association with erections, no association with having erectile dysfunction if you have urinary symptoms. We've actually studied this more and more in the field, and we do recognize that there may be conditions having to do with how the prostate and the lower urinary tract and the urinary outlet area function to allow a man to urinate well that may also be related to how erections occur. And when there's something that has something to do with either circulation or nerve tissue or various other things that have to do with urination, it may also impact erections and vice versa. So it's interesting that we really have come to be more enlightened that men having urinary issues may also have erectile dysfunction issues, and there may actually be common conditions on the pathophysiologic level, fancy word for meaning disease state mechanisms, that may actually cross between these areas. Now, I don't mean to diminish that there could be emotional and mental aspects of sexual dysfunction and erectile dysfunction specifically that are at play. Conceivably, all presentations of erectile dysfunction can impact your best sense of well-being. Having erections is a mind-body experience. Things have to work together. And so it's not alarming that there have been some studies that have looked at some disease associations along the level of emotional predictors that also may suggest a man may have trouble with his erections. And that may range here from things that include pessimistic attitude, depression, marital change, even employment change. These things have been looked at more closely, and I think we again are trying to take a real look at what are things that may relate to why a man's struggling with his erections. Now this slide I think is kind of important because what it conveys here is that we may all have some responsibility in our best health, and lifestyle issues can impact on erections. So a person who has any of these sorts of things, really poor state of health, overweight, all these kinds of things, cigarette smoking, a big factor. We used to think 20 years ago that if you were the Marlboro man, you had great erections. Well, the Marlboro man doesn't really have great erections, is the truth. He's got a limp cigarette is what's going on. And so the truth of the matter is this has been studied, and we recognize that anything that offends your vascular system can impact negatively on your best erections. And things that we may be able to consider could impact that we can take some responsibility for. In fact, as I talk about here a little later in the talk, maybe that's our first line of addressing the problem, trying to do better with things that you can take some responsibility in. I mentioned goal-directed evaluation and treatment. And again, you can just read from the slide. This refers to the fact that we accept more and more that patients have a role in deciding what they think they want to do, particularly now that we have, in our current era of time, various therapies that are lesser invasive, reversible, meaning you try them. If you don't like it, put it down, try something else. So you can see that we have options here that really comes down to just what may appeal to you based on the nature of the therapy that we can offer. So know that we are very receptive to what we call the patient-centered approach in the management of this kind of problem. I spoke about the partner having a role, and there have been studies that looked at this very critically. So I'm not just making this up off the top of my head. I know you guys are probably saying, gosh, Dr. Burnett's making this a tough medical talk here tonight. But I think you guys want to hear some facts, all right? I'm going to tell you some real stuff to take home, not just spewing my thoughts and opinion. But here's some real facts. There's been studies done that show that partner interview has shown that the partner, at least 58% of the time, can have a role in deciding about the nature of the problem and perhaps how to go about addressing it. And therefore, the spouse has a very important role in going about management of erectile dysfunction. Again, I applaud the spouses coming out tonight. You can see all the different reasons here. They may have a perspective on sexual issues. They may have insight into the quality of their relationship. Role even in terms of the problem themselves. And sometimes partners may have sexual issues themselves, and that can impact negatively on the man having a good response. And maybe we need to treat that couple as a whole and try to figure out what else we can do to help the female partner as well. So I think we're increasingly understanding all of these concepts, including the partner role. Now I mentioned the cardiac risk assessment, just to bring you back to that. We recognize that there's a coexistence of ED, erectile dysfunction, and cardiovascular disease based on various kinds of population-based studies, basic science work. And so where we are in this field is that we recognize that we should classify patients as either high risk, intermediate risk, which is in between the high and low risk, and recognize that any man presenting with erectile dysfunction may have other health comorbidities, maybe things that we just haven't picked up yet. I can tell you, I've seen patients in my clinic who come to see me and have never had a known cardiovascular problem, but they're seeing me almost as their interface with a clinician. We're addressing the erectile dysfunction. I suggest that they go see their primary care doctor to get a further evaluation, and lo and behold, that 50-year-old gentleman who never had a heart issue, we're finding out he may have a little bit of a heart issue. Okay? So there is this bidirectional relationship many times, and we always are thinking more and more about anything that's going on with an erectile dysfunction presentation pretty much represents perhaps a vascular disease presentation, and we're very cognizant of making sure that men get their wellness checkups if you're presenting with erectile dysfunction. And interventions can range from getting cardiologic referrals with appropriate testing for high-risk patients. For low-risk patients, we're talking about other kinds of things that it may even be very basic, just routine health monitoring and even considering lifestyle modifications, perhaps is the first step to help address the problem. So, what's step care approach mean? Okay, it means a kind of a stepwise thinking about how to manage erectile dysfunction. Initially, it's a matter of trying to assess what the disease presentation or the complaint of the patient is. How many say you have a problem with your sex? Well, what is it specifically? We may ask questions like, are you having trouble getting erections? Is it a libido problem? Sex drive, that's libido. Is it orgasmic? And then the nature of the problem. Is it how severe it is? Is it trouble getting erection, maintaining erection? A little bit of both. Do you have erections upon awakening in the morning? Many times that's kind of a poor man's test of some elaborate diagnostic tests of just whether things are working. Because we know that men involuntarily have morning time erections upon awakening, and that's just normal body physiology. So there may be questions to help us get a sense of, really what is the nature of the problem, sorting out all the boundaries of questioning on that level. We also want to get a handle on any other medical or surgical or any other conditions that may play roles. That's why we do intake forms many times in our clinics and help us know, do you have any history of heart disease, diabetes, are you on medications, things of that sort. So all of this is very helpful for us to sort things out. A physical examination generally is done. We want to just carry out a basic evaluation of a person's general health status, their circulation status, nerve status, genital area examination, may even check the prostate. So all these things go into our evaluation related to this problem. And you can see I've listed some of these things here with that drop down. There may be some laboratory tests we may do, okay? And this just shows you the kinds of things. Glucose may have to do with diabetes, lipid problems, urinalysis. Sometimes I've picked up guys just on a urine sample that they have sugar in their urine, and they never knew they had diabetes. That doesn't happen commonly because many times patients are already under the care of another physician. But sometimes just coming to our clinic, maybe out of the blue, never seen another physician, we'll just check a urine sample, and on a little dipstick, there's sugar in that person's urine. They're actually having some diabetes, and they didn't know it. They did not know it. This CBC, complete blood count, looking for any kind of blood disorder, sometimes thyroid stimulation hormone, and even serum testosterone. So I'm going to take a moment to talk about that. Everybody asks, well, gosh, how important is getting your testosterone checked? Well, it can be important. It may have more to do, though, with a man's libido than his erections, but we do recognize these things do have some sort of connection, okay? And many times, at least evaluating for a man's testosterone level may help us understand whether there is a contribution of having the right kind of male hormones in your system that facilitate the best erectile response. So that may be part of our evaluation as well. So what else do? We talk with the patient, get the partner involved. We discuss what our options are and ask you how to help us decide what is the right thing. It's a shared decision-making process. We discuss therapeutic options. On occasion, seeing a specialist of a higher level may be necessary, not just a urologic surgeon who deals with erectile dysfunction, but sometimes I may want you to see a cardiologist. I may want you to see a neurologist. I may want you to see a psychiatrist who may specialize in some things that I'm picking up. So you can see different specialists may play roles. Endocrinologist, somebody who checks hormones, may check for other kinds of hormonal relationships to things. And there may be a whole host of tests that we'll do. And again, this just gives you a glimpse of things, not to have you memorize or think about things, but there's various kinds of tests that we may do to help characterize what's going on with blood flow in the genital area. And may do these tests under certain situations, not always, but sometimes. There are many reasons why seeing somebody like me is important. And sometimes I'll get referrals from my internist colleagues because while all physicians and even nurse practitioners and other healthcare providers, I feel, can address erectile dysfunction, and they should. They shouldn't just deny a patient evaluation, because anybody who's a bit of a medical professional should be able to do almost everything I've talked about thus far. But sometimes coming to see me as a surgeon specialist may be indicated for complex presentations, and sometimes that's why it's very important to maybe see somebody that does something a little more involved than some of the frontline care providers that you may see. I mentioned goal-directed assessment. Goal-directed therapy is the complement to that in terms of thinking about how far you want to go with your diagnostic workup, how far do you want to go with the therapeutic options. Again, we value the patient and his partner's interest in what they think they want to pursue. And I think that really is kind of a tenet of how we go about our evaluations these days. Treatment. This slide, it kind of tells it all. You know, what do we do to offer for therapy for erectile dysfunction? First line, in general, we try to look for anything that we think is potentially correctable. So if somebody's smoking 3 packs of cigarettes a day and saying, Dr. Burnett, I can't get an erection, the first thing I'm going to say is, you know what, you might want to cut out some of that cigarette smoking. You know, I mean, you know, if somebody comes in and I really think that they could get a little bit more physically fit, I might suggest, you know, why don't we talk about incorporating a little bit more fitness in your life? Because I think these things are being studied as having some potential benefit in restoring a person's ability to function. So it's not just running to the doctor and say, give me a pill and I'm going to keep smoking and just eat at McDonald's every night. I mean, you got to help yourself a little bit. And so, I mean, so first line is to think about some of the things that we might call risk modification behaviors. We talked about the stepwise treatment approach, okay, and I'm going to tell you what that means is we got pills, we got vacuum pumps, we got injection. You'll see what I'm talking about. And they kind of go from the least invasive to the more invasive alternatives. And I generally want guys to think about least invasive things first. Okay? And then I always like to say that even when I think there's a physical problem for many presentations of erectile dysfunction, it's possible that it does torment a person or his spouse or the couple, and having somebody who may be more along the lines of a psychosexual therapist can always play roles in that patient's evaluation and management. So step care approach here is, you've heard me just mention all these things: stop smoking, try to follow a good diet. All these kinds of things may be, I think, first line management to think about in terms of trying to address one's erectile dysfunction. Counseling is always helpful, although that's a little bit outside my arena. Androgen replacement therapy for a man who may have a low testosterone level. There's various forms of therapy there. The most common therapy that we tend to use these days are patches. And I can certainly address that more if anybody has a question, if the audience wants to hear more about that. But there's a whole host of things that have been done in the past, from injections to subcutaneous pellets and this and that. And most commonly we do these patches and then follow up and see if a testosterone level has improved and assess that man's subjective response. Have you felt better in terms of your sexual response? So that's how we go about thinking about that if a testosterone level is low. Oral therapy, we have the PDE5 inhibitors. That's Viagra, Levitra, Cialis. The fancy word is PDE5 inhibitors. You may remember that, may not, but that's what they're called. That's a class of drugs they're called. And then maybe some other more experimental things and some things that are available only in other countries like Europe that may work through brain mechanisms to help with the erectile response, not approved here in the United States. Second line, options such as intracavernosal injection, that is injecting medication that induces an erectile response. I'll tell you about that in a moment. Therapy where you put it through the urethra for drugs, and a vacuum pump. Again, these are all second line. Why? Well, they're obviously a little bit more intrusive than first line. A little more intrusive, a little more invasive. So that's why we kind of consider them second line. Third line therapy, by and large, refers to surgeries. Okay, and there's various surgeries that we may do. Obviously, they're much more invasive than anything else that's first and second line. All right? We'll talk about that here in a moment, but just want to give you a feel of the overview of kind of the options that are currently available. PDE5 inhibitors, I'm just going to kind of go through this here. You can read through the slide. This refers to Viagra, Levitra, Cialis, oral therapies. We coach men to use these drugs. You take them about an hour prior to intended sexual activity. They augment your erection response. They require a certain level of your normal physiology to which the medication helps you get a better response. That's how these drugs work. So they do require at least some level of your own intrinsic function. They work in about 70% of men, not everybody. We do know that there's some side effects that are related to that, from headaches. About 16% of men have headaches. 10% facial flushing. About 10% have dyspepsia, indigestion kind of sensations. About 4% have nasal congestion. Visual disturbances occur in about 3% of men. These are all transient side effects. They're not long-lasting. Not everybody has them. So, but there are, like any drug, potential for side effects. Why does it cause these things? Well, it helps blood vessels expand and open blood up in the genital area, but also other places, and that accounts for some of these kind of side effects. Contraindications, the main one is anybody on nitrates, nitroglycerin, patches, paste. If you have a little, nitroglycerin pill, like Fred Sanford, oh man, oh, you take, no. If you're anything like that, we cannot give you this medication, because the interaction between these medications and nitrates is it can lower your blood pressure to where you can be unresuscitatable. Okay, we don't like that, right? We don't like that. So it's just that the truth is just these medications in your system. Who saw that film with Jack Nicholson, with what Something's Got to Give or something like that, and he was in the ER and he said, you take this medication. He's like, no, well, good, we can give you this, but if you take the medication, it could kill you. He's like, oh, they take the IV out. So we always have to be cognizant of people on nitrates. Alpha blockers refers to a kind of antihypertension or blood pressure pill, and they're just precautions. We don't like these medications taken at the same time because it could have a blood pressure lowering effect, but it's not a true contraindication. So what are the second line options? Vacuum pumps, injections, intraurethral suppositories, topical therapies that are put on the genital area, but these things are not really effective, and they're more kind of investigational. They just don't really work in terms of penetrating the genital area and having a good erectile response. So really we have things here, here, and here. So let's talk about it. All right, so what is this? Looks like somebody got something out of the automotive shop and played around on their genital area. What this is a vacuum pump, vacuum erection device. It's external, okay? This is probably one of the most basic ones, but they're more sophisticated ones even now. And what you do is you actually put a cylinder over the penis, bring it down to the junction of the penis and the scrotum, creating kind of a seal. And then this system here goes to a device that creates a vacuum effect. It can be hand-driven. It can be motorized. And what it does then is by drawing air out, kind of a negative pressure situation, it makes blood get drawn up into the penis. Then you release a constriction band to the base of the penis, remove the cylinder, and then you have this constriction and an engorged penis that you can use for sexual activity. So that's how this all works. That's the vacuum erection device. It's completely external. And when you're done with sexual activity, you just shimmy the ring off. Okay, so that's what the vacuum erection device is all about. And it has generally good efficacy rates. Satisfaction rates, if you look at the literature, are kind of all over the map. Some men find it to be ideal. Some find it to be challenging. It is, for some, something that's not put into the body, no piercing anything or puncturing anything or doing anything else, but on the other hand, it's something you have to kind of do to your body. You have to take a time out, honey, bear with me a moment, I got to do this. And some can incorporate this in lovemaking, some can't. Sometimes it's challenging to be more spontaneous when you have to do different things to your body. So therein is why satisfaction rates may be a little challenging for some, just because it's not a very spontaneous aspect of sexual activity if you've got to do something to yourself. Side effects, they're minor. Bruising to the penis area can occur. There's a pivoting effect, because when you put the ring around here, the constriction band, it doesn't really engorge everything upstream from that. So everything kind of just pivots a little bit, and maybe that's not quite natural. But nonetheless, you can still, once you have that engorgement, it can be used for sexual activity. But for some, that's a downside. So these are kind of the things that some men have talked about. Certain patient disease disorders may be concerns for using this kind of device. All right, so what is this? This is the intraurethral suppository, okay? And so don't fear, this is not the true actual size of this thing, nor is this thing here. But at least most men, I think, would admit that, I hope. But in any case, what you do, this is about a 3-inch dispenser. You place it through the urethra, press the end of it, it dispenses a little pellet. You remove the device, you massage the penis, and the medication gets absorbed through the lining of the urethra and finds its way to the main erectile bodies of the penis, and by a pharmacologic effect produces an erection. So this is what this is. It was introduced in 1996. The medication that's typically used here is one that can induce an erection effect. It's called alprostadil, and you have to be taught how to use it. Many men do find it to produce some fullness or engorgement, but the ability to produce great rigidity with this sort of thing may not be quite as successful as the injection of medication. I think we've come to learn over the years that perhaps about 20 to 30% of men probably get the best rigid responses with this technique. So therein, it may not be successful for all men. It may have to do with just how it gets absorbed, how some men can get a better erection with it based on their anatomy in the genital area, but it's not uniformly high success. So if a guy is looking for something that's highly successful, we're more than likely going to go to the vacuum pump or the injections. But this is an alternative for a man who wants a medication route, but is not too attracted to the notion of a needle in the penis. Can be local side effects here, very minor things. But the main issue is how well does it work, and I generally counsel guys to say they can work, but may not be quite as uniformly successful as some of the other options. All right, so what's this? This looks like some sort of torture device. In fact, this is intracavernosal pharmacotherapy, penile injection therapy. The original introduction of this actually was, a scientist who presented at one of our urology meetings about 25 years ago, self-injecting himself before he went on stage with a few thousand people out there with baggy sweatpants, and he only talked for a few minutes because the rest of the time he just walked up and down the aisles with his pants pulled down and demonstrated how effective this therapy was. So don't worry, we're not going to get into that tonight. We're not going to get into that. But this has been effective. It has been demonstrated for about the past 25 years. And what it is using a diabetic injection, a needle, with a small needle, 28 gauge needle. You can draw up fluid, medication that has properties that induce blood vessel tissue to relax and let blood engorgement occur. And you inject towards the side and the base of the penis. And we teach a man how to do it. We come in, we go through a training session. Make sure you can do this competently. And so this is an option for some men who want to explore this. The success rate generally is in the order of 95% of men using it. Again, there's training involved, but we make sure that we find the right dose because we want a man to have a rigid response, but then be enough to go down within the hour. And it may differ for different men. All right, so know that we actually have you come in and do an initial test injection. We get an initial sense of your ability to do it, whether there are complications, and what dose makes sense. So therein is why we do have you come in for a training session. And if everything goes well, then we write up a prescription and say, here you go. Here's some prescription for some medication. Here's a prescription for the diabetic injection needles, and go to town. But we want guys to do this safely, and that's why we have training sessions before you get started with this sort of thing. In terms of side effects, penile pain is relatively minor, although one of the medications, alprostadil, can cause a bit of an ache sensation in about a third of men, 1 out of 3. And we use that commonly initially, because it's a safer drug to use. But then in some, if they can't tolerate it well, we have to go to some of the other medications. I want to show you what those are here in a moment. Just give you a feel again from a bird's eye view what we have to think about in terms of therapies. Penile fibrosis refers to some scarring in the penis. If you get a lot of injections, sometimes the tissue where you're injecting can scar a little bit. Usually this is in the order of 2 to 5% of men. So even long term, it's not the majority of people with a tiny diabetic needle, injections done, not multiple times a day, I hope, unless you got a lot of free time on your hands. But it can be done safely, and scarring to the penis is relatively minor. But we always let people know about it. Priapism is a risk where you get a prolonged erection, okay, and that can happen if you use a higher than necessary dose. And that's why we do this training in the clinic first, to make sure we establish a dose that's safe. Because we don't want anybody having a prolonged erection that is like not getting circulation in and out of the penis. And if your erection's staying up for hours, that's kind of a dangerous thing. Okay, so that's what priapism is all about. This just gives you a flavor of the kinds of drugs we use. There's all kinds of things from Caverject, Edex, Bimix, Trimix. So if you hear these terms, what it refers to is some of the different drugs we use, and sometimes we use in combination, because the different drugs can have different kinds of pharmacologic effects, And sometimes we have a drug that works through this chemical mechanism and this chemical mechanism. We can put them together, they may synergize, and that man who may not respond to the initial drug may be able to respond to two drugs together, working in a synergistic way by two different biochemical mechanisms. Or three drugs together is called trimix. So bimix is alprostadil and phentolamine, trimix is alprostadil, papaverine, phentolamine. All these are fancy things, but just give you a bird's eye view of how we try to get, if guys are attracted to this notion of doing injections, how we try to go a little further if necessary to give them the best pharmacologic effect if we can. Okay, so this just gives you a feel of what it is, and this tells you about our success rates by and large that can range up to 90% of men using injectables, that we can get them something that'll work for them. All right, so what's this all about? Penile prosthesis. This is third line. This is a device that's put inside the penis and the pelvic area. Nothing is hanging out the body. If we do a surgery device on you, you look as normal as anybody else at the Y showering. Nobody knows anything, because nothing's hanging out of you. No plastic is exposed. But this is a device now that's all self-contained, that has three components. It's called a three-piece inflatable penile prosthesis. There are some other more basic ones, but this is probably the one that's more like the Cadillac. So the guy who really wants one, I feel that I want to give him the best device he can get. So you have the one piece here, which is the cylinders. Second piece, the pump. Third piece is the reservoir. All of this is connected by tubing. The fluid that is in it is the standard saline that you have with an intravenous line, like when you go in the hospital, you have an IV. So it's safe fluid. It's not like floating silicon particles or something like that. It's normal saline. And what happens is the penis is a typical flaccid state. Fluid is up in the reservoir. When you're ready for sexual activity, you reach to the scrotum, you manipulate the pump, and you pump it up. You pump fluid that transfers fluid from the reservoir to the cylinders. And the penis comes up, and you're going to have sexual activity. And when you're done with sexual activity, you manipulate the pump, pressing it at a certain release valve, and that allows the fluid to exit the cylinders and go back through the tubing back to the reservoir. So that's what this is all about. That's a penile prosthesis. And yes, there are men who do go further to that next option if they feel the other options are either not desirable, ineffective, or there may be contraindications to use any of the other options. They move forward to a third line option. So you can read from the slide. There's various reasons to think about doing this sort of thing. Generally, a man has to have a good sense of the familiarity of using this sort of thing. Yes, it is a surgery. That's why it's third line. And it really is irreversible to the extent that we've changed the structure of the penis once we put this in. But for some men, they've explored all the other options and they're not working, or they're just not successful for them, or not desirable for them, so this may be an option to explore. There is a risk for device infection. About 1 in 100 men can get an infection with a foreign structure in their body like this. While we put these in under great sterility with antibiotics and all this sort of thing, it is true that just like somebody can get an infected artificial hip or an artificial heart valve or this or that, sometimes we'll have a situation where 1 in 100 guys, we may have to take it back out, get you on some intensive antibiotics, and maybe decide sometime later whether we can put another device back in for you. But the risk of infection is low, but not non-existent. So we always make sure you hear the truth about some of that. But it does have high success rates, and we do consider, whether a patient really has all the right considerations to go to surgery. And this is really a good, thorough discussion that we have with each man to review his health status, expectations about surgery, and so forth, if he's inclined to consider this option. I always throw in a slide about penile vascular surgery because everybody always asks me, I heard about, you can probably go in and do some sort of bypass for the penis, and maybe that can help blood flow in there. Well, the truth of the matter is, this has been studied, explored very thoroughly about 20 to 30 years ago. It has not worked like doing a heart bypass, just maybe because the circulation of the penis is just much more intricate. And trying to do a certain bypass hasn't really successfully worked except in very select circumstances. And these select circumstances you can read right from here. Is if there's a main artery that feeds the penis deep internally without getting all the anatomical terms. Generally, a guy who's had a traumatic accident, a 20-ish-year-old guy who fell somewhere and straddled something and injured himself, only in these select circumstances. The penile vascular surgery, revascularization, does not apply to that 50, 60-year-old guy with long history of health conditions, cardiovascular disease. The unfortunate thing is the blood vessel changes throughout many of the vessels in the penis area will not be changed by just doing a bypass of a certain little vessel in the genital area. It's only if we did find a discrete area that actually tore or something like that in a very healthy guy who was functional until he had that accident, and then we have to go about fixing that. That's the only person we really think about doing a penile revascularization surgery for. All right, so I always just like to make sure I'm clear about that. Because always people say, well, I've heard about this, is this an option for me? And it generally is not for that older man who may have other health things that have changed in his body. This is not really an option there. Also, venous reconstruction, the idea that blood flows into the penis by arteries, they drain from the penis by veins. Maybe if we tie off some veins and make sure they don't drain back so easily, we can help a man have a better erection state. This has been studied as well in the past, and the unfortunate truth is it's more complex than that, and just tying off some veins has not been a very successful option for men to be able to retain their erections. And there's various reasons for that, but I won't get into all the details, but really that's not an option either. So the idea of doing various kind of blood vessel reconstructive surgery has not really been a mainstay in our armamentarium for treating erectile dysfunction. That's the message I'm saying. What about follow-up issues? Well, we always try to reassess, what are the medical, what are the psychosocial issues that a man may have, and can we readdress those? If we initially pursue one therapy, maybe it's working, maybe it's not. Maybe there's been some adverse reactions, drug interaction effects. Maybe there's a need to adjust the medication. Maybe it's a matter of just making sure that we understand how you responded and what your expectations are, and whether a therapy meets your goals, and whether we need to explore something different. You may try the vacuum pump, don't like it after a few months. You may want to try the next thing, penile injections. Hey, let's welcome that. Come back on in. Let's explore that. So in other words, I think we should have some follow-up. By no means should we just say, here's some pills, see you. Don't want to see you again. No. We should try and respond to you and then try to figure out among our options what can work so that you can get back in the game and feel that we're responding to what your needs are. So by closing, what are some of the key points of the talk here tonight? Well, first, that you are not alone if you have erectile dysfunction. It affects 20% of men in general, and if you have some high-risk features, it could be much more significant. Cardiovascular disease and diabetes are highly associated, but prior pelvic surgeries, treatment for prostate cancer, whether it's surgery or radiation, can be associated. Our basic evaluation, as you saw from a step care approach, is to evaluate the complaint, review medical history, carry out an appropriate exam as needed, do some laboratory tests when needed, maybe do elaborate testing if it's really necessary, and then try to proceed in a very thoughtful way with options in terms of diagnosis and treatment with the role of the patient and partner contributing to that discussion and trying to figure out what makes sense for that couple. So I will close there, and I hope that was informative to you. Hopefully, if you have some questions, I'll field those now. And make sure you leave here tonight feeling you're much more informed. And I appreciate your coming out. A tribute to you, I think, to want to be more informed. I always admire my patients who want to be more informed, so I appreciate your coming out.